Let's understand this picture first of all. This is right atrium. Blood from right atrium goes to right ventricle, and right ventricle forces the blood to the pulmonary artery, and it goes to the lungs in these pulmonary capillaries, and then all bloods are collected after oxygenation, goes to the left atrium via this pulmonary vein, goes to left ventricle, and left ventricle propels blood to the aorta. So in the aorta systolic pressure is 120, diastolic pressure is 80. So a left ventricle has to generate 120 mmHg pressure to push the blood in the aorta, because this circuit is very long. Aorta goes to descending aorta, and descending aorta branches into different arteries and goes to different organs, so it has to travel long distance. So left ventricle has to generate greater pressure, about 120 mmHg. But this circuit, you see, this is short circuit, pulmonary artery, capillaries and vein, so blood has to travel a short distance. So in this side their right ventricle do not have to generate greater pressure. If right ventricle can generate 20 mmHg systolic pressure, then it is sufficient to propel the blood to the left side of the heart. So systolic pressure ranges about 15 to 30 mmHg, and diastolic pressure is like 8 to 12 mmHg, right? So you can see here, like less than 30 mmHg systolic pressure is able to propel the blood to the left side of the heart, and the mean pressure in this side is mean artery pressure is 10 to 20. If the mean pressure rises more than 20, then we call the hypertension in this system, right? Or if the systolic pressure is more than 30, we call pulmonary artery hypertension. So if there is elevated pressure, we need to find out why there is elevated pressure in this circulation, because that much pressure is not required, right, to travel here. If there is elevated pressure, there might be some cause, we have to find out. So one cause can be right ventricle is not contracting with greater strength, but it is contracting with the same strength, but this connective tissue in the pulmonary artery side is proliferated because of any connective tissue disease, right? The elasticity of this wall is lost. So even though right ventricle is generating systolic pressure of like 20 mmHg, here pressure will be more because this wall is not distensible, right? So if this wall was pliable, then pressure will be reduced, but this is stiff. So if this is stiff, the pressure will be high, right, in this side. Other cause can be right ventricle is generating greater force, like normally it generates systolic 30, but let's suppose right ventricle has to generate like 40 to 50 mmHg pressure. Why right ventricle has to generate greater pressure? Because there is some obstruction in the pathway that is not letting the blood flow to this side, right? So what are the obstruction? So one obstruction can be like in COPD or interstitial lung disease, because of hypoxia these pulmonary arteries are constricted because of hypoxic vasoconstriction. So if these are constricted, what happens that blood will have difficulty flowing to this side, so right ventricle has to generate greater force to push the blood to the left side of the heart. So one cause can be this lung pathology that is causing hypoxia. Other cause can be like left ventricle failure. Let's suppose left ventricle has failed, so blood is not able to go in the aorta, blood is backing up in this side and this backs up in the pulmonary circulation. So if the blood is backing up here, right ventricle will have difficulty propelling the blood through this system to this side. So right ventricle has to generate greater force like 50 mmHg, 60 mmHg to propel the blood in this direction, right? Other cause can be like if there are thromboemboli here, and there are small thromboemboli in the capillaries, right? So if there are these thromboemboli, these are acting as impediments like obstruction. So if there is obstruction, right ventricle has to generate greater force to propel the blood to this side. So in other causes, except the pathology of this pulmonary artery, right ventricle has to generate greater force. But I told you, if the pathology in the artery itself, then right ventricle is not generating greater pressure, but whatever pressure is generated by the right ventricle, here the pressure recording is high. Are you getting me or not? If you measure systolic diastolic pressure by here through catheterization, and here it will be normal, but here it will be recorded high because this wall is stiff, right? Because of some pathology in autoimmune connective tissue disease, those can occur. So what are the causes? One can be the pathology in the pulmonary artery itself. Second can be lung disease like COPD, ILD. Third can be left ventricular failure. Fourth can be chronic thromboembolic conditions like causing pulmonary hypertension. So why do you need to differentiate this? Why do you need to find out what is causing this? Because we have to address the underlying cause, right? If there is thromboemboli, we have to address this. If there is left ventricular failure, we have to address this. And in addition to that, where to give vasodilator? So if there is high pressure here, then can we give vasodilators in all cases of this? No. Let's say there is left ventricular failure and blood is backing up in the pulmonary circulation, and right ventricle is generating enough greater pressure to push blood on this side. If you dilate this, there is no problem here, there is no pathology here, right? So if you dilate it, what happens? More blood goes via this circulation and more blood backups occurs here. So it worsens pulmonary edema. Or if there is hypoxic vasoconstriction due to COPD, ILD, if these are hypoxic vasoconstriction and if you dilate this, so more blood goes here. So blood is going more, but ventilation is not in that proportion because of the COPD, ILD. So there will be VQ mismatch. So it will further worsen. So in lung disease, left ventricular failure, we do not give vasodilators. Like you already know vasodilators like prostaglandin I2, endothelin antagonist, calcium channel blockers, riociguat. These are vasodilators. So we have to decide in which conditions we have to give. In CTEPH, if there are thromboemboli in some capillaries, if we give vasodilator, then the blood can flow better, right? So in that condition, in chronic thromboemboli conditions, it can help, right? Take another condition. Let's suppose the problem is in the pulmonary artery itself because of the connective tissue disease. Here will you give or not? The problem is not anywhere else, but the problem is here only because it is not compliant, it is not distensible. So here if you dilate it, it will improve the condition because the problem is here. So you can directly address it, right? So vasodilators will be very much useful in the primary pulmonary artery hypertension, but you have to check whether it is responsive or not. Because of this pathology, sometimes what happens that this calcium channel blocker, sometimes it responds but sometimes it does not respond. If calcium channel blocker do not help, then we have to choose these vasodilators like prostacyclins, analogs, endothelin antagonists, riociguat, right?